Thank you all for coming. I'm Dr. Matthew Rogalski. I'm the director of the Wound Institute in Ocean County, Toms River, New Jersey. And my partner, my co-presenter today, Kathy Milne, who needs no introduction, who is very, very well-renowned, world-renowned, is also going to be doing this presentation with me. And it's a great honor for me to be here and to be with Kathy because she is such a learned and visionary type person for us. This talk is going to be on some integrated solutions for diabetic foot ulcers. It is supported by a grant from BSN. So I thank them for also, and the organizers for inviting me to be here. It's a great honor to be at the SAWC to give some lectures to help all of my fellow physicians and clinicians and nurses learn about diabetic foot ulcerations. It's very near and dear to me. I come from a long line of diabetic patients. I even had to amputate my own father's foot because he got mangled by some inappropriate treatment. So I'm here to help you as much as I can and go through all of this really good information about how to do these things. These are our disclosures that we do speak for a lot of companies, and we get compensated for that, but I make no mistake that both of us, we do the things that we do for the good of our patients. We don't have an allegiance to anybody, to any company. I do a lot of work with stem cells and all kinds of things of that nature, but we use these products because they work, because they have great science behind them, but they have great clinical evidence. You're going to find in this field that there is a lot of some interesting research that is put forth, but not a lot of scientific evidence behind it. But these products that we're going to talk about, you have significant clinical trial data. Not only do they have great science to show can they work, but that they do work in these settings. So we're going to start talking about specific aspects of offloading and then the treatment of the wound bed as well. The chronic inflammatory nature that occurs in this entity. Why does that happen? Bioburden, cellular senescence, increased nidus over white cell migration to the area, destruction of the extracellular matrix, all those factors contributing to the chronicity of this wound. So I'm fortunate to give you a little bit of a lecture on total contact casting. Why does it work? How does it work? Why is it not used more often? Is what's always been very interesting and perplexing to me. We are in a big, huge pandemic with diabetes. When you think about 1 out of every 4 people in the world are going to be diabetic by the time 2030 rolls around. In this country, that'll be 2050. We see more people getting amputations. Every 30 seconds in the world, a leg is amputated from diabetes. In this country alone, there's 10 limbs are amputated every hour. In this country alone, with 1 out of every 2 people in the world being obese, in this country, it's about 1 out of every 3 in obesity underlying that chronic sterile low-grade inflammation that leads to the initiation and propagation of diabetes and its deleterious comorbidities and the consequences for that. We see a lot in my centers. We treat a lot of patients who are diabetic who have dialysis, very difficult to heal. People with dialysis, it strips all their factors out of their body, keeps them chronically anemic. So when you have peripheral vascular disease and anemia, very difficult to heal these chronic wounds. So these stats are only growing. We are going to have a big problem coming up here if we don't educate our public, increase our compliance aspects, and do the right treatment algorithms to really help these people. Because otherwise, we are going to have a major problem. 30 million diabetics in this country. There's 8 million that have it, but don't know they have it. And we have 80 to 90 million pre-diabetics in this country. I guess it's better that we don't live in China since they have 500 million pre-diabetic people in China at this point. So I think that with new cases coming out of 1.4 or 1.5 million new cases every year of diabetes, put that in perspective, 200,000 cases of breast cancer every year. 1.5 million of diabetes. Do we hear a lot about diabetes? Do we see pro sports and runs going on and all kinds of people talking about diabetes? The money that we are spending on diabetes, and the mortality rates, the morbidity rates, the hospitalization, the cost of treating diabetic foot ulcers at $36 billion a year just for a diabetic foot ulcer. It's getting amazing that's going on. So hopefully we can get more of this out to the public so that they know. And yes, it may be the 7th leading cause of death, except diabetes is always on. When you see a lot of these death certificates, they always have a diagnosis of diabetes, but they think it's the heart attack or the stroke that caused the death. But diabetes underlies vascular disease. They do go hand in hand. So the percentages of these people are increasing. Is it the diet that they're eating? We're not exercising enough. Sedentary lifestyles. People not understanding diabetes. I've had people to say to me, Doc, I can eat anything I want. I take a shot. Or Doc, I can eat this. I take a pill. I don't have diabetes. I've had actually people that didn't even put it down on their report forms when they come in as new patients that they're not diabetic because they take a pill. They don't think they have the disease. And when you start talking to them about the comorbidities, about how it will kill them if they do not control that, it'll eat them to the bone. They still don't understand. Nobody ever told me that. I didn't know I could go blind. I didn't know I could have kidney failure. I didn't know I could have my leg amputated. Nobody told me that. So it's, I think from our perspective, that we need to do a lot of education for these people. We need to let them understand, because with the money that we are spending, and this is just from 2012 statistics, $36 billion a year in the treatment of diabetic foot ulcerations, $30 billion in venous leg ulcerations, pressure ulcers up to $24 billion a year. It's amazing how much this money, and with people living longer, and with that tremendous inflammation that occurs just as we age, not even the premature senescence that diabetes causes, and that premature acceleration aging process, it's only going to get worse and the costs are going to go up. So we need to find effective treatment algorithms so we can treat this problem effectively, get these patients out of the hospital, get them out of the clinic, and hopefully keep them in that healed state for it. Look at the cost that diabetics, when they start to develop a foot ulceration, it's the number one reason diabetics are admitted to the hospital is for diabetic foot ulceration. No other reason. It's the number one cause of lower traumatic non-extremity amputation. We could see that the cost of it about $27,000 a year in the treatment, simply for one diabetic foot ulceration, about $52,000 after about 3 years of treatment. But the time for this to occur and the amount of hospitalization that occurs, the amount of treatment that does, it's staggering how bad that is, increasing almost on an exponential basis. So the money that we spend and the time that we consume, diabetes and its related complications of $300 billion a year for that treatment. So you always wonder about treatment algorithms. There's 13 societies that put forth treatment guidelines for chronic wounds, diabetic and venous leg ulceration. Why are these not being followed? Why are we not adhering to those regimens? A diabetic foot ulcer in Maine is treated differently than a diabetic foot ulcer in California. Why is that? If you, God forbid, you have some type of cancer, you get the same treatment no matter where you are in the country. Why does that change? Why is there some difficulty in understanding the underlying mechanism and things that we need to do to offload? Because when you see somebody with a diabetic foot ulceration, 84% of all lower extremity non-traumatic amputations are preceded by a diabetic foot ulceration. So I think that we have to understand these problems, and that when people go to get amputated, now, I'm not saying that there's people with hammered digits and problems that do require sometimes a surgical cure for that, to reduce a biomechanical deformity that can precede. We can heal anything. The question is, how long does it take before it reopens? Maybe that should be the sixth phase of wound healing, is maintenance of these wounds being closed. And there are sometimes in biomechanical problems that you have to do something surgically. So there is always an instance. It's a great field that we can combine medicine and surgery and do a lot of good things for people. But the problem is that obviously when we do have a leg amputation, a 50% mortality in 3 years, when you go to AKA and you add dialysis on top of that, there are some reports that show it can be as high as 80% mortality within that 3-year period. It's an interesting schematic, isn't it, when you look at that just a neuropathic ulceration itself has a higher mortality rate than breast cancer, prostate cancer. It's pretty eye-opening. How many people actually know that? I didn't know that before I seen these slides. And then when we add peripheral vascular disease on top, because diabetes engenders that phenotype, diabetes causes vascular disease, endothelial dysfunction, and a whole host of other problems. They can't dilate their arteries to get blood where it is needed in an emergent condition. So peripheral vascular disease, diabetes going hand in hand. When they have vascular disease, the mortality rate is quite staggering. It's very eye-opening to see that when you can relate this to people. 9 out of 10 people never knew that. They didn't understand that. They don't understand. Even the patients don't understand the severity of the disease. That it has a greater mortality rate than most cancers do combined. So this is kind of the trifecta that we see in the diabetic population. Neuropathy. Now, don't forget that sensory neuropathy, yes, they can have a very difficult time healing. Their nerves lose their insulating layer. It's hard to transmit signals to the brain. But also there's something called motor neuropathy. So when you do not stimulate your muscles in your foot, they atrophy. And when they atrophy, you start to develop claw-toe deformity. You start to develop something called equinus. Sugar gets deposited within the tendons. They lose their elasticity and extensibility. Can't get the front of the foot up, right? Gets too tight. So that's why we call it equinus. So they're hitting the front of the foot and the heel at the same time. So they build all that pressure underneath the forefoot. We do Achilles tendon lengthening to help that. But motor neuropathy is devastating. By the time they're diagnosed with diabetes, they've lost 50% of the muscle mass in their foot at the time of their diagnosis. So with atrophy of muscle, exposes all those bony prominences to even higher pressure. And then you have something called autonomic neuropathy, which affects every system in the body. Every system in the body. Can't dilate arteries to get to areas where they are needed. Brain, heart, healing. So autonomic neuropathy causes tremendous dysfunction in the vasculature. That's why a lot of diabetics get very dry, scaly feet, right? They can crack because they don't stimulate their sweat glands to make enough oil, skin oil, sebum, okay? So autonomic neuropathy, when you think about neuropathy, it's that whole spectrum. Sensory neuropathy, autonomic neuropathy, motor neuropathy, and PAD. Diabetes genders inflammation within the blood vessel. Diabetes affects every cell in your body. Every cell from fibroblasts and endothelial cells to your stem cells as well can become this entity called senescence. So peripheral vascular disease, the chronic inflammation, endothelial cells start pumping out tons of these inflammatory mediators. You get very significant fibrosis, line of the wall injury, and then you start to get stenosis and then frank occlusion, and they can't dilate their arteries to get blood to parts, endothelial dysfunction. And then, of course, infection. So 10 trillion bacteria on your skin. You have a chronic wound, you're always going to have some type of bacteria that's in there. Does that mean that it's an infected wound? Does it mean it's chronically contaminated? You hear all about this thing called biofilm, which is a tremendous, tremendous field of study now that we're understanding the inflammation that's triggered by biofilm, causing the continued white cell migration down through, and keeping these wounds open, keeping them in that inflammatory state that you're familiar with. But because they have a capability, a decreased capability to fight infection, to phagocytose pathogens, to reduce that inflammation, they are at heightened risk of tremendous infection, the ability to restore that tissue integrity and to protect that from those. So this is kind of that trifecta. When we talk about the ability of the pressure to increase, especially under the metatarsal head and especially under the heel region, it continues to build because they can't feel. You and I get a callus under our foot, and we say, man, this thing is really bothering me. I got to get this looked at. Something, they can't do that. So they come in when they start to see drainage on their sock, or they start to smell something, or their foot gets red, or they start to get a fever, they start to get pain. And then they end up in the emergency room. So, and that's where the limited amount of mobility that comes in from the constellation of these tissues. And then they get an injury. They hit their foot. They stub their foot. They wear a tight pair of shoes to a wedding. They go to some kind of event and they want to wear a nice tight pair of shoes or something, and it rubs and it creates a blister. And now we have an insult into that area. Makes it very difficult for us to heal, for it to fight infection because of these trifectas of problems that they have. And now they're coming to see us, and then we have to remedy that situation. So when we think about those challenges that we have with people with neuropathy, how are we going to get the pressure off of that wound? I could put 50,000 pieces of stem cell grafts, all kinds of things that we're experimenting with. But if we don't find a way to relieve the pressure that is on there, and we'll be showing you all those clinical studies that TCC has a tremendous healing rate in and of itself. You see at the conference all the different new things that are out there, all these different cells we're looking at, and we're injecting cells, and we're putting those, and all this good stuff, which is great science. 560 clinical trials going on right now with mesenchymal stem cells throughout the world for every age-related disease from head to toe. But we have to find a way, a simple thing to do to take the pressure off, and we can effect a cure in a tremendous amount of people if we use those things. So my question is always why, if we consider TCC to be the gold standard, why is it only used in 2 to 6% of all these cases? I can never understand that. It's simple to apply. I don't even put them on anymore. I have 5 wound centers, and I see 5,000 wound patients a year. But our people, we have tremendous nurses that can do an amazing job, and they've learned to put them on in 3 or 4 minutes. Very simple, very easy to do, and you're down moving, seeing other patients. So we have to understand that is why, again, from the neuropathy, from the constellation of tissues, they get very hard, they get fibrotic, they get that equinus deformity, they start to build this pressure that is underneath that. And they can't dissipate. They can't bring the front of the foot up so that we can walk heel to toe. So that pressure is going to accumulate in those spots that we talked about until it builds and they start to get a callus. And they get blood in the callus. Then they may get a blister. And now you're into frank ulceration. So you even see a callus that has blood in it. That's a big problem because they have so much pressure. They're busting the capillaries in the skin because of that focal pressure in that area. So total contact cast then is able to reduce that. Reduces a tremendous amount of pressure off of the foot because of a simple design that it has. It spreads that pressure out. It limits that motion. It decreases the time that the foot is on the ground so that pressure cannot build. Transmits that pressure from the foot to the leg. So it's like if it actually is kind of floating inside the total contact cast. We even try to make braces to emulate that. It makes it very difficult. And a simple design with a simple cast can alleviate a tremendous amount of pressure and has tremendous healing rates that we'll show you through clinical trial work. So by reducing that pressure, that friction, that shearing forces, so now you have skin that, because of the autonomic neuropathy, can't relieve that self. It doesn't have that elasticity to accommodate the swelling, because neuropathy also engenders neurogenic edema. We see a lot of diabetic people, they'll say, my feet are swollen, my legs are swollen. Neuropathy can do that as well. Now, by coupling those two together with the abnormal biomechanical aspects, you build tremendous amount of pressure, callus, blood in the callus blister, ulceration. So you can see that by spreading that pressure out, and we're able to move that pressure from the foot, put it back onto the leg in a comfortable manner. I put people in a total contact cast. They may have a big wound on their foot, but I tell them they can go to the store. They can go wherever they got to go. They're protected. They have the pressure that is offloaded. They want to do a little bit of exercise and sit and kick their legs up and down and move. It really doesn't bother me because they are protected, and more importantly, they are offloaded from that. Force plate analysis showing the decrease in that pressure. As you can see, with people that are even barefoot in shoes and with cam walkers. Cam walkers are interesting, but people say that instant total contact is an interesting idea, except it only takes about 60% of the pressure off. But people can take boots off. They can remove different types of darker wedge shoes. So that's the problem with the cast. You can't take it off. If I had people try to take it off, I've had people use tin snips and Dremels. I had one lady's husband try to take it off, took 2 toes with it. So, it happens. Oh yeah, he was using the Dremel, and he started going through it. He said all of a sudden it just started bleeding because their toes were off as he was going through that. So you'd be surprised. They get claustrophobic, but it keeps them protected so they can't remove those problems. It's interesting that we talk about some of these contraindications. Just about all my diabetics have arterial insufficiency. I use it for heel ulcers. I use it for ankle ulcers. I think that if you are seeing these patients often, we put one on and we bring them back in about 2 days. People that have big hammer toes and bunions, you have to be careful. But the great padding system that's in the BSN cast offloads that area. But I think it's the frequency that you do see your patients. Arterial disease, diabetes do go kind of hand in hand. Now, do we use it on somebody that has pus and everything pouring out of their foot? No, they probably should be into the hospital. But there are times before people that are stable, that may have deep wounds that go down to bone and tendon, before I'm doing a surgical procedure, I'll put them in a cast. Some of that pressure and the tension and the swelling, and control some of that biofilm before we are doing surgical procedure. And after surgical procedures, I use total contact cast a lot. Because how many people that are that aged after having these big procedures are actually going to be able to use crutches, stay off their foot? It's really difficult. This way, when you're in a cast and you're post-surgical, they're going to have to put weight on. They're going to go to the bathroom. They have to get up something to eat, do things of that nature. They're going to put their foot down. So at least it's a great aspect also to use it in the post-surgical realm as well. But again, people that have arterial disease and all these functional abnormalities, you have to be able to monitor them and see them. We don't put them in a cast and say, we'll see you in 3 weeks. We see them at least twice a week so that we can do that. Some pictures of some people that we use. Heel ulcers, I use it all the time. Classic diabetic neuropathic ulceration that you see, and we're going to fix that. But these are just some of the pictures that we're utilizing different types of wounds for people with Charcot foot, all right, after ankle surgery, tendon repair. You'll see these problems with a lot of docs now are using collagen wraps and doing all this stuff. No evidence for it, but people that are using that, they think that it reinforces no histological evidence, no randomized controlled trial to show that it does anything. So this poor lady had one of those big fat wraps on the back, and it ulcerated through, pulled her incision apart. So we had to do a lot of different surgeries to fix that. But she's in a TCC afterwards because it protects her, still allows her to ambulate. She's diabetic. She has psoriatic arthritis. She has problems. She's got to move. She can't sit on her rear end for 6 to 8 weeks. And so in a total contact cast, she is supported. Another gentleman, that gentleman on the left that you see, came in to see, has this wound, this foot going on for 9 years, which doesn't make any sense to me. So 9 years, just walking in a surgical show. Tremendous equinus problem. Wounds that go down to bone. Who leaves a foot? Like, look at the pressure increases from that. I mean, his toes and foot are turned to the side. So that's a surgical case that we are going to fix, but we use a TCC for him so that we can decrease the wound and decrease the inflammation and the drainage and everything. And that wound shrinks down very nicely, so it's less tissue for me to excise. So TCC is so versatile. It has so many applications for it. Another diabetic foot ulceration, this lady's had multiple surgeries on her foot. It's interesting how the configuration of her foot is like that. So there are going to be times when we have to incorporate surgery with our medical treatment for that to effect a cure because the biomechanics are skewed. If I can put her in a TCC and get it healed, it's not going to stay healed though. Wounds over tendons. This is on the ankle too. We use that to immobilize. So when we start grafting and things, we don't want any pressure and tension on the wound. But he's a rheumatoid arthritic with vascular disease. He needs to be able to do some movement as well. So total contact cast protects us from that. These are some of the studies that we show, all the different studies on total contact casting that is going on out there, and how quickly a lot of these wounds can heal just with total contact casting. Putting things into the wound, a little bit of collagen to use so that we can absorb the inflammation and other dressings that we have that we're going to talk about here today to absorb drainage inside the TCC as well. But utilizing a total contact cast by itself has significant randomized controlled trial data to show that it does work significantly better than a lot of different dressings out there. You've probably heard that we can't look at the hole in the patient. We need to look at the whole patient. The diabetic ulceration is just a systemic manifestation of multiple comorbidities. So we have to address all those aspects. There's not one single thing that we can put on a wound and we're going to cure everybody. It's a whole spectrum of things that we need to do so that we can effect those cures. And when we start to look at all these different, meta-analysis is taking all these different RCTs and looking at them and combining them and trying to glean that data from those. And it's significant. Look at these healing rates just with total contact casting. 4 or 5 minutes to put on. First time I've ever used one, it took me 7 minutes to put on. So it's simple and has a tremendous cure rates far in excess of what now has pre-market approval out there. So spending $3,000 for a particular type of graft, when you can spend minimal money in the use of a total contact cast that has a healing rate of 88%, it's pretty significant. So look at the different types of offloading that we see, all these different types of, I love these Darko wedge shoes that you see that only have the heel and leave the front of the foot open and the people come walking in with their foot this way. And when we can just use a nice total contact cast, people can walk, they can go shopping, go to the mall, do what they have to do. Maybe they're taking care of a spouse who's infirmed. And this way they can put weight on their foot, they can do the things that they have to do, and they are offloaded, and ultimately that they are going to be protected. So look at the healing rates that are compared to these types of things, DH walkers and cam walkers, and even like I talked about the Darko wedge, the half shoe thing. We have people break their legs, break their ankles with that because those heels are very thick, very difficult for them to walk. I mean, an 80-year-old guy that has neuropathy that's going to be, and neuropathy affects their balance and their coordination as well. And be putting in these half shoes when you can have a nice cast that is very, very similar to their walking motion and be able to offload and be able to protect those. So instead of using TCC, like we talked about, the Darko wedge, even we see people with surgical shoes that come in and have diabetic ulcers for years just with a surgical shoe. Somebody has to be seeing it. Somebody's changing the bandage. Wouldn't you say to yourself, wow, why are we using just a simple surgical shoe? The wound hasn't healed in a year. And you think we should try something different for that. So when we look at wounds that if we don't see that 50% reduction that's in 4 weeks, that's always an interesting level where it comes about. Should it be longer? Is it shorter? It's just a retrospective analysis of that. I know a lot of LCDs are going to follow that. If we don't see 50% closure in 4 weeks, we move into the realm of advanced modalities. And TCC is really an advanced modality that you could be using from day one. 88% cure rate that you could start on something from day one to be able to affect your patients and to help them and to get rid of this problem. Because the longer that this is going to stay open, the greater risk for problems we're going to have, infection, amputation, hospitalization. So when we look at some of the, again, more of the evidence, you have to always glean this. You'll see all these people that are in these companies have different products and things, and they say, we've used it on 10 people. They did great. 10 patients. Everybody did great, doc. You got to try this. You got to take a look at it. Now we have studies on TCC, 500-600 people, probably even more now that we've used. We put it on a TCC on every diabetic ulcer that I can get it on. All right, people could be claustrophobic. I'll give you some Xanax at night if you need. But you need to use this. If you don't use this, we're going to have a very difficult time fixing this. You're going to get infected, and you could end up with an amputation rate. Because that's all they always say. They had the wound for a year, but as soon as they start seeing you, after 2 or 3 weeks, why isn't it healed? Why isn't it healed? How come it's not healed yet? I don't understand. It's been coming here 3 weeks. Meanwhile, they've had it for a year. So it's always interesting how from the patient's perspective that we should be able to heal these wounds in 2 or 3 weeks. So again, average healing times are amazing. The 88% cure rate, and And now we have good randomized controlled trial data to use that. Now, my good friend Kathy Milne is going to tell you about the wound microenvironment. She's going to take care of that, and at the end we'll talk and we'll have questions.
Thank you, Dr. Rogalski. So all roads will lead to amputation, as Dr. Rogalski said. So, and there's a number of reasons for that, and we've already discussed that. So the interesting thing is that we need to start looking at how we can get that wound bed to look good. So there are 3 R's to wound care, and they are remove bioburden, rebuild that tissue, and then, as Dr. Rogalski said, we want to look at the whole patient, not just the hole in the patient. And we know how difficult it can be to manage people's blood sugars because that is what got them there in the first place. So that is a huge challenge, especially from the wound care provider's perspective, because we are not the endocrinologist, we are not the PCP. At best, we can hope for is trying to get them to listen to us and then try to work with their other providers. So when we think about removing bioburden, we have to think about what is this bacteria. So we have both planktonic and sessile. So the planktonics are the ones that we're kind of concerned, not as concerned about. They're the ones that are free floating. They aren't really impacting that wound. Those are the ones that we're culturing and then treating, and we probably shouldn't be thinking about what is floating in the wound, but we should be thinking about what is attached to that wound. These are the guys that are susceptible to topical and systemic antibiotics. What we should be thinking about and being much more worried about are those sessiles. So these are the guys that attach and then they cause critical colonization. So once they attach and they actually try to take over the world, and they go from what I call the colony to the urban center. And so once they are an urban center, it becomes very problematic because they start using the host as their way to survive, and they put up a defense so they don't get demolished. And that's how we get that glycocalyx and that slime that is typically seen by some people, and then really what we're really seeing is a lot of fibrin. So the problem is that when you're trying to treat these people with topical or systemic antibiotics, it is really ineffective. And we cannot culture them using our typical bedside swabs. So we sometimes don't even know what we're treating when we treat them. Now, the other interesting thing about this is that, how do they really work? So these bacteria, the sessiles, actually have a mechanism called hydrophobicity. And so what they do is kind of think like magnets. When you put two magnets together, they're attracted. And why do they do this? Well, they want to communicate with each other. They want to be able to get attached to that host. They want to be able to kind of rest and chill out for a little bit. And then they also want to kind of use it to hide from the white blood cells that are coming in to get them. And so when you have an organism that is very hydrophobic, we actually see increases in biofilm formation. And the problem is that we've always thought about treating biofilm in a way of, instead of trying to beat them at their game. And in fact, what we should be thinking about is joining with them. And one of the ways that we can do this is by putting on topical dressings that address the hydrophobicity. So the other thing about bacteria that we need to know about are the endotoxins and the exotoxins. The endotoxins are actually inside that cell, and when you kill that bacteria, those exotoxins come out and actually cause more inflammatory mediators to come into that wound bed site and cause more inflammation, which, as you know, actually can be very detrimental to the wound. Those exotoxins are the ones that are hanging out on that intact bacterial wall trying to destroy the host again, and the white blood cells that are trying to come in and take care of them. So that's the issue that we are always worried about, is we can stop those exotoxins, but when you kill the bacteria, what do we have to do about that endotoxin? Now, the interesting thing about biofilm is that we know that it comes back within 20 hours, can restart and set itself up, which means, we've all learned about using, our debridement methods to kind of reduce our biofilm propensity and the amount of biofilm that's there. The issue is that we can't get that patient in every single day to do a mechanical debridement. And so by the time we see them on day 7 or maybe even day 5, if we're lucky, we can get them in a little bit more often if their insurance will allow us. That biofilm is already come back up, and it's an issue. And when we try to do systemic antibiotics, we're all under the gun now not to use systemic antibiotics. We know that there's lots of side effects, but now there are regulations depending on where you work. So people who are working in long-term care actually have these huge restrictions now on them with regard to the use of topical and systemic antibiotics. And we're seeing that a lot of the healthcare systems, the ID folks, are really kind of monitoring and giving us lots of feedback on our uses of antibiotics. And of course, we don't want resistance. We already have resistance. In Connecticut, where I practice, my MRSA is now only sensitive to clindamycin. It is no longer sensitive to doxycycline or Bactrim. So we're in a bigger problem there. Now, typically, how do we get rid of this bioburden? We obviously debride it. Wound cleansing is extremely important. And then the topical antiseptics and topical antimicrobials. And there's lots of them out there, and you can see the whole list. We do have data with regard to some topical antibiotics and also negative pressure. And then dressings also can actually impact bioburden. And of course, maggots actually has some very, very good data to support its reduction in biofilm. Now, when I said you can't beat them, you should join them. And this is where DACC technology comes along. So DACC is, and pardon me as I phonetically spell this out or say this out, diactylcarbomoyl chloride. So this is a chemical that actually can coat different materials that actually is hydrophobic. So what it does is that the bacteria is actually drawn to this chemical and actually will bind that bacteria at the dressing surface. So it's very interesting. Now, it's a relatively new technology in the United States, a couple years, about 4 or 5 years. However, it has been in Europe for a long, long, long time and is actually the leading technology to reduce bioburden in that wound bed. So a lot of the European studies are old that I'm going to talk about. So when we first start looking at some of the data, we see that we have a 6-log reduction in 2 hours because it binds this bacteria really quickly. And once you bind them, they don't release any exotoxins. You're not destroying them, so you're not releasing endotoxins. And then their metabolic rate slows. And you can actually literally remove them out of that wound bed. So this is a study by Stanarowski who looked at 543 people who underwent emergency C-section. They either got DACC or they got a standard surgical dressing, which was really a dry dressing. And before everybody says, oh, that's really not a great comparison, we've got to remember 85% of the U.S. uses a standard dry dressing or a wet to dry dressing in wound care. We are the elite and we know better. But this is what people use. And so when you start looking at this, looking at the infection rate in 1.8% versus 5.2% is pretty significant, and especially when you tie those with dollars with regard to hospitalization and outpatient costs. And remember, every insurance company has big data on us, and they know exactly how much we're spending, who's having problems, how many visits, and actually probably how long you are actually spending with the patient. So when you reduce your surgical site infections, you actually will improve your patient experience, which will actually give you an extra 30% more increased reimbursement, and it will also improve your organizational's data in terms of outcomes, and everybody is looking at those outcomes. So when you start looking at silvers, now remember, silvers do not bind, they actually destroy. And so this is a study that looked at 20 people in each group, and I know that is small, but and I know Dr. Rogalski said, we do have to start thinking about how we want to improve the strength of our studies, but this was really kind of a pilot study for in proof of concept only, and what he did was actually try to look at people as a wound bed preparation prior to skin grafting. And so when they looked at the bacterial loads, really no significant difference between the two groups. At day 0 and then day 4, before they were grafted, you could see the statistical significance between the two groups. Unfortunately, what we didn't see in this study, because it was not either a primary or secondary outcome, is how these people did with their split thickness skin grafts post-operatively, because that would have been really fun to see, because in theory, the better your wound bed prep is, the better your take is going to be. Now, when we look at the newborn, so part of the issue that when we look at all those other types of dressings and antiseptics that we have available to us, is that they have either no data or it is contraindicated in the neonate or the newborn. And so that limits our options a lot when we have complications in that subset of patients. Now, this study looked at over 2,000 newborns, and they looked at using DACC versus the standard of care for the umbilical cord. And while they found no statistical significance between the group, this is another option to use because you have no chemicals, it's just a binding physical property of the dressing. You're not going to hurt that little kid. You're not going to hurt that baby. You have a lot more options when you can see those kids in the hospital, because you now have another way to treat them and not have to worry about any toxicity. So what about biofilm? What's the biofilm data? Because that's really the first thing I asked. So we looked at, they looked at MRSA and Pseudomonas. So this was 1 hour after the biofilm. So you can actually see the strings inside the dressing, the actual fibers. And then after 3 hours, you can no longer see the fibers because they're being coated. And when you look at Pseudomonas, you're seeing pretty much the same thing. You can see the fibers after 1 hour. Pseudomonas isn't quite as liking it after 1 hour, but after 3 hours, we're starting to see those guys climb on. So when you're using this dressing, there are a couple things you need to know about. Number one, you should make sure it comes in contact with the entire wound bed. And this comes in different forms, so you can use a number of different formats so you can get your best conformability. Also, match your dressing to how much drainage you have. And then most importantly, you can't use any ointments with this because the lipids will interfere with its antimicrobial properties. And last but not least, once you have figured out, I'm going to get rid of that bacteria, you have to rebuild the tissue. That's your next step. So we really are thinking kind of synergistically. And so you have to get an extracellular matrix down. And there are a number of components to that. And you can see them listed here. So why do you need an extracellular matrix? Well, a couple things. Yes, it is a scaffold, and it does helps you have those receptor sites bind to those growth factors, but it does this thing called dynamic reciprocity. So if I went to this table here up front and I pushed them all, what would you guys do? You would push me back, right? So there's that intertake, and so I push you, you push me back, and that's what that extracellular matrix does. It does a lot of cell signaling, including calling in fibroblasts, neutrophils, and growth factors to the site. So you need that extracellular matrix. If you don't have one, you're in a bigger problem. And why can you not have one? Well, either your extracellular matrix is being degraded, and that could be from excessive inflammation, too much MMPs, and that's usually bacterial related, or it can be a disease, such as cytokines related to metastatic cancer is known to degrade an extracellular matrix, or you just can't make one. And you can't make an extracellular matrix, again, related to disease, and diabetics are associated with the poor formation of extracellular matrix, or you're just plain old, or I'd like to say mature, because nobody is old these days. So this is a great example of a wound that looks clean but doesn't have an extracellular matrix, except, maybe a little bit over at 10 o'clock. So it looks good, but I have no extracellular matrix being put there. So when you put in an exogenous cellular matrix, you do a couple of things. So they are available in a number of formats. A lot of people have them, they're pork, they're chicken, there's fish now, and beef. But what you do is one of the things that putting on an exogenous extracellular matrix dressing in the form of collagen is that it acts as a sacrificial matrix. So if you have too much MMPs, you're going to come in, it's going to take care of this and not take care of your patient. Second of all, you actually can be chemotactic, and that can actually get your neutrophils and your macrophages back in and actually get your fibroblasts to come in, adhere, and start to proliferate. Now, the thing is about these matrix dressings, especially those collagen dressings, is that the closer you are to the human structure, the better you're going to be. And so, as you can see, when you have native bovine collagen, it looks very similar to human dermis. And the native structure is really key for both the scaffolding, so you have your 3D, but also the way that scaffolding is set up, it actually prevents enzymatic degradation, which is extremely important. And of course, it's easier to handle. So when you start looking at the data, when you actually compare a number of collagens together, you can look at how the binding is. And so when the more proteases you bind, the less inflammation you have in the wound and better outcomes. And you can see here that native bovine collagen is significantly better at binding than some of the other collagens out there. Now, when you look at growth factor protection, again, that scaffolding helps, but when you bind those MMPs, the more MMPs you bind, the better off you're going to have for your growth factor protection. Again, looking at the data from Weigand's in 2016, presented in the Journal of Wound Care, looks at the number of growth factors in growth factor stabilization. And when you're looking at fibroblasts, again, the important part of getting that proliferative stage going is getting those fibroblasts in there, which are the precursor to collagen. Again, when you start looking over a period of time, you actually have increased fibroblast seeding. Again, all in vitro, but very, very interesting and compelling work. So what's it look like in real time? And these are my patients. So this is, typically my patients I do 1 day a week at a wound center, and because I'm the nurse practitioner, I get the resource poor people. I don't get the more easy people. So most of my patients are homeless or extremely poor. This patient has obviously diabetes. She had a hemoglobin A1C, which I actually thought was pretty good for my patients. The typical other issues that we typically see in a diabetic patient. She had a left medial foot ulcer. She was hypergranulated, but then she put all the caveats on, and we all get those patients with the caveats. You can't debride them. You can't do chemical cauterization. This thing is very hypergranulated. You can practically see the biofilm in there. She doesn't want any hyperbarics. She doesn't want a surgical evaluations. She just says, well, I'll do a cast shoe, and we know the data on a cast shoe, and I'll only do blood work. Otherwise, just put something on it and take care of it. So we did control the edema. We know edema is one of our big enemies. We actually used elastic tubular stocking that we can actually cut off on a roll. I think without mentioning a brand name, we all have seen those things. It provides about 10 millimeters mercury compression. And then we actually reduced our bacterial load using DACC. And then she actually improved dramatically, and she kept on continuing to heal. So, and then we actually switched her over to a collagen dressing. This is another patient. Her hemoglobin A1C is more like my typical patients, a little bit under 10. And she had an inpatient admission for cellulitis. She had a surgical debridement, went off to long-term care, spent 6 weeks. She got IV antibiotics. She had gotten topical silver dressings. They had tried negative pressure wound therapy, which she refused because she just didn't like it. and she refused to have a total contact cast. We tried to do that. She again said, I can't stand it. And she actually failed her gait evaluation, almost fell in the office. And we never want to take our wound patients and send them to orthopedics. That's never a good idea, right? So we did do a curette debridement. We started off first with a foam-based DACC dressing. And then we ended up going to the collagen dressing. Now, she would come in and we would do the curette debridement and place that bovine collagen on. Now, here's the thing. Most people would say, oh, this is terrible. It's disgusting. This wound is awful. We shouldn't be using this dressing. This is what you should expect after usually 1 week, sometimes 2, when you're getting a very good response to your wound. We call it caramelization. First of all, the hyperkeratotic tissue is kind of the weird-looking color that is normal. It's not bad. And also in that wound bed, you want to debride that. But actually what you're doing is setting up that extracellular matrix and getting that wound to improve. As you can see, my wound size and dimensions actually have reduced, and actually by day 42 she resolved. So she did extremely well despite many, many hurdles, including not being offloaded adequately and having a very high hemoglobin A1C. So I just want to summarize before you guys go back to the afternoon. We want you to think about the physiological issues in that wound bed, address that bioburden, rebuild tissue, and then do the simple things such as offloading, because using a synergistic approach like that can actually improve your outcomes. So with that, I want to thank you all very much. I would like to thank BSN for the educational grant for today. And thank you very much.
Thank you.